Hello, I'm Peter Norton. Thanks for joining us on ScheinTV. Every dentist knows that modern dentistry is very much a material science, which requires us to keep ahead of, or at least abreast of, the latest developments in physics and chemical engineering. In an increasingly crowded dental market, both in terms of practitioners and products, the ability to deliver ever more durable and ever more aesthetic solutions for our patients has become a commercial necessity. Tonight, we'll be talking about some ceramic materials that are on the leading edge of performance in terms of strength and aesthetics. To help us to understand what some of these materials can offer, we're joined by two experts in aesthetic, restorative and implant dentistry, and they'll both be sharing some of their recent cases with us. Shortly, we'll also have a patient in the chair, and we'll be showing some real results in real time. So on to our guests. Dr Anthony Mak obtained his Bachelor of Dental Surgery from Sydney University, and then went on to complete his postgraduate diploma in clinical dentistry oral implants. He graduated with multiple awards and since then has worked with some of Sydney's most renowned practitioners. His interests lie in dental technologies and advances in materials and techniques. Welcome, Anthony.
Thanks, I'm glad to be here.
Dr Christopher Ho is a prosthodontist here in Sydney. He is the founder and principal of Care Dentistry and has completed his Bachelor of Dental Surgery with First Class Honours, a graduate diploma in clinical dentistry, implant dentistry, doctorate in clinical dentistry, prosthodontics from the University of Sydney. He also has a Masters of Clinical Dentistry, Prosthodontics with distinction from King's College London. Fellow of the Pierre Fauchard Academy, having lectured nationally and internationally, Dr Ho has held faculty positions with the University of Sydney, the Global Institute for Dental Education, the Academy of Dental Excellence, and is a visiting clinical teacher at King's College London. Welcome, Chris.
Hello, Peter. Welcome, everyone.
By joining us this evening, you are eligible to claim 1 hour of scientific CPD. We'll let you know at the end of the presentation how to go about claiming your CPD certificate. So, Chris, we all know that dental materials are ever evolving. What is it that you think is pushing that change?
Well, Peter, dentistry is changing a lot. I mean, we know that there's so many advances in materials that we're using, adhesive dentistry, ceramics, and really, it's evolving so quickly. It's very hard to keep up to date. So hopefully, in this next hour, we'll share some experiences that we have with ceramics and bonding and how we use that in our practices. So it's a real pleasure to be here, and also with my good friend Anthony Mak, who shares some beautiful cases today. So let's start. What we do as dentists, we want to replace tooth structure. We want to treat disease, but we replace tooth structure with materials that have the biological, aesthetic, but also properties that reinforce tooth structure. We know about the principles of biomimetic dentistry. I know, Anthony, you know a lot about that as well. But we're trying to reinforce teeth. We're doing things in a more conservative way, a minimally invasive way. In the past, we relied on GV Black principles of extension prevention, retention form, resistance form. We know about Schillingberg and Goodacre, all those sort of principles that we've used to apply. It's very different. It's changed completely.
We're challenging the boundaries, I guess.
Yeah.
So it sounds as though it's replacing tooth structure, but also preserving and conserving, from what you're saying.
Very much so. I mean, we know that we have this, what they call restorative cycle. Brantley in 1995 talks about this. When you carry out a restoration, the next restoration becomes a bit larger and larger again and again over time. On social media, there was this money tooth that was going around, and the money tooth was basically, it's not a good thing. It's basically a patient would receive a restoration. The next restoration would be larger. Then they might need to have a crown. Then they might have to have root canal treatment, endodontic treatment, maybe retreatment if it failed, possibly extraction and then an implant. So what I'm really passionate about is trying to carry out minimal invasive dentistry. A dentistry that is trying to conserve tooth structure. Tooth structure, to me, is really the key to long-term dentistry for patients.
And would you say we're trying to either stop that cycle or at least expand it or delay it?
Well, I think we have to be careful what we do to teeth. In the past, it was a very reductive approach. We would carry out metal ceramic crown preparation or an amalgam restoration where we would create undercuts for an amalgam, for a metal ceramic crown. We would take off a lot more tooth structure than we need to now. The dentistry has changed completely.
And I would say bring up this slide here, which is some really simple statistics from our country in Australia that our patients are living longer. No longer can we, the lifespan of an adult nowadays is up to about 80 years old. That's the average lifespan. So half of those patients will live longer than that. Now, if we look at the statistics, back in 1967, the average lifespan for a male was 67.9. That money tooth that Chris was talking about only needed to get to 67 years. And then they could have the extraction, have a denture for a few years, and that was what the expectation was. But nowadays we need to conserve tooth structure, and I second that, Chris. It's so important to try to extend that dental cycle and try to preserve as much tooth, but still trying to achieve the goals of good, sound, functional restorative dentistry.
So this was some literature that I dug up, and you'll see that Goodacre and also Jackson found that after fixed prosthodontics, so crown and bridge work, that patients would require endodontic treatment about 6 to 11% of the time. So we want to be minimally invasive when we carry out treatment. I really like this study by Sorensen and Edelhoff in 2002. What they did there was a gravimetric analysis. In other words, they weighed the tooth after preparation. And you can see here on the preparation with a porcelain laminate veneer, you would take away 16% up to 30%, depending on the preparation design. And all ceramic preparation took away 62% when you carried a chamfer margin, and up to 68% of the tooth was removed with a rounded shoulder, while metal ceramic crown preparation took away 72%. So we know that with all ceramic preparation, we have 11% less tooth structure removed. But along with that, we may not have to carry out the typical crown preparation. I know that, Anthony, yourself, we do lots of onlays, 3/4 crown preparations, much less invasive restorations.
And Chris, the Edelhoff and Sorensen did exactly the same study for posterior teeth, and they tested it on a common an MOD existing restoration. That will be one of the most conservative, one of the most simple restoration we will convert to an indirect. If someone has had an MOD existing restoration, and they did the same study, and they showed that if you did an onlay, an MOD onlay preparation, you would be only removing about 39% of the tooth structure. If you were doing a metal ceramic crown and you did the same thing, you removed the MOD cavity and then you converted that to a metal ceramic crown, you would take off about 75% of that tooth structure. And that's a big difference. And why using all ceramic restoration allows us to achieve these type of restorations compared to where conventionally, like you said, we would need to do a lot of resistance retention form with our traditional metal ceramics.
And Chris, a couple of slides ago you mentioned the possibly sort of 10-11% chance of needing endo after fixed pros. Yeah. Was that restoration a full crown or more of an onlay?
That's a full crown.
Okay.
So I guess in our practices, really the treatment objectives, especially in my practice, have changed when we're looking at restorative dentistry of our patients. That we want to be minimally invasive. That's our key goal when we're trying to do a restoration. We want to choose good materials. We want to have good materials that last and is going to be tested throughout the test of time. We're always trying to use a digital workflow because we can see the benefits of using digital dentistry now compared to the traditional analog approach. And we're always trying to achieve a biomimetic or a tooth or restoration that emulates the natural tooth. I mean, we always try to achieve that and gaining aesthetics. And most importantly, by doing this way, we want to be precise and reproducible, that we can always achieve this kind of results for every single patient and every single restoration. Sometimes things go wrong. We want to be able to reproduce those restorations and still conserve tooth structure. Do you agree, Chris?
I agree, very much so. So, if you look at the types of materials that we have available, really there's 3 different types. We have, resin matrix ceramics, these new materials like Cerasmart,
hybrids, yep.
The hybrids of ceramics. We have polycrystalline materials like zirconia, and we have lithium disilicate. And lithium disilicate, I use a lot in practice, and I know you do as well, because of the fact that we can adhesively bond these restorations. A little bit different to zirconia. But if you look at these materials, how they work is, these are lithium disilicate crystals. These are synthetic materials placed into an amorphous glass matrix. And there's really 2 types on the market, Emax and Lysipress. Lysipress is a new material that has come from GC, and this material has a very unique technology. It has this HDM technology, or high density micronization. And basically what that is is the crystal structures are very, very small and they're very densely packed together. So I know what you're finding is that you're having slightly better value, slightly more opacity within the restorations, and that's one of the downsides of the alternative materials.
I think this kind of material having a bit more high value is exceptionally good for younger patients who would like to have that white or brighter teeth. Or you don't have that graying effect that some of the other materials can give us. But most importantly is that sometimes we do indirect restorations for teeth which might be slightly darker or different colors in different teeth, and being able to mask that easily without using still a minimal preparation and still being able to mask the darkness shown from under the tooth. These are some of the things that are why I really like this material.
Backing up a smidge, higher value, essentially brightness or something else?
Yeah, opacity as well. Yeah, brightness and opacity, because they correlate together. If you have something that has low opacity, obviously the value will drop. If you have a high opacity, obviously naturally that tooth will be of a higher value.
And the other advantage is that this material is slightly stronger, around about 460, 470 megapascals of flexural strength. So definitely some advantages of this new material. If you look at this next slide, you'll see that the crystal structure is very small, very, very small particles. So if there's any plucking of the crystals out, there's less sort of degradation of the surface, higher polishability, and lower solubility in acids and those sorts of materials.
So I wanted to show you this first patient. This is Vicky, and Vicky has given me consent to use her photos and in this case. And this is a case to demonstrate what we call 3/4 veneers, and whereas traditionally if we would need to use other approaches where we couldn't bond to, we would definitely need to use some full coverage crowns. So Vicky presented to me, was referred by a colleague of mine, a periodontist who actually I went through uni with, and with some friends that were in my year. So basically Vicky's concern was that she wasn't happy with the proclination of her teeth and some of the older veneers that she had, and she was hoping for an aesthetic improvement. So she came in with a fairly high expectation for aesthetics. And when I first looked at her, I said, look, I could consider cutting back these veneers and then cutting more tooth to actually retrude her teeth so that it's less proclined. But then I said, look, I'm probably going to take more tooth structure away. And so one of my key things, and going back to my key objectives, was the minimally invasive. I decided to recommend Vicky some orthodontic treatment first to retract those upper anteriors so that when I do remove those veneers, I'm not going to be removing any more teeth than I had to.
I think it's also important to note that you're also conserving enamel. Enamel gives you that predictable bond.
That's right. And I'm going to show you a case later on where we were able to create minimal preparation into full enamel. So this was Vicky after her orthodontic treatment with a friend of mine, and we retruded the upper anteriors. And this is pre-preparation. Basically, this is her smile before we decided to carry out some veneer preparations. So I sent this to a ceramist in America, a very well-known ceramist by the name of Bill Veneers, and he basically did a digital mock-up for me. And when he sent back, I just wanted to show you where he did a digital mock-up and achieved great shape. And on one side, on your left side, he used the 3D print. He printed that mock-up. And then on the right side, he actually milled the mock-up. And you can see the detail is slightly different. They still both achieve very, very good results. But Chris, in a fully milled mock-up, he was able to get a little bit more detail. And also he can finish that a little bit with hand. And that's just something that for us who are doing this type of dentistry, for us to be aware of.
Is it not possible to do hand finishing using a milled mock-up?
A milled mock-up, yes, if you mill it.
A 3D printed, mock-up.
No, because that's a solid model. It's a hardly cured resin. So you would have to get a handpiece on that. And to get the fine detail, you would then roughen up the surface of the resin. You probably wouldn't get the detail. If you were wanting to finish it by hand, you would definitely want to mill it in wax, I guess. Yeah. So we tried the mock-up onto Vicky. This is our pre-preparation. We could create our depth guides. This is the minimum thickness that I wanted. I wanted about 0.5, 0.6 millimeters. And then once I removed her existing veneers, I found that she had all these old interproximal composites. And one of the things I want to show is that I generally don't like to fit, new veneers onto old restorations, Chris, and I'm not sure if you concur with that.
Yeah, I think you should always try and manage to place your margin on the tooth structure.
That's exactly right. And so you can see those overhangs on her existing restorations. You can see it here on this side there, and that was causing a little bit of gingival recession here on that side. So basically we removed the restoration and we decided in this case we had to do 3/4 crown preps. Whereas, because I was able to bond lithium silicate, I could achieve 3/4 crown preparations. Whereas if I was using a zirconium material or metal ceramic, I probably would have had to go a full coverage. And that's where it goes back to the study we talked about by removing more tooth. So I sent the impressions to Bill, who created some really nice shape and finished off some really beautiful veneers. This was first go, and I wanted to highlight a key feature of this material and how we achieve excellent aesthetics was, you see, these are nice pressable materials where you can really get good surface details and clean pressing and clean margins. And then we were able to fit the final result, and she was very happy with this aesthetic. This aesthetic result was natural. It wasn't too white. She wasn't after something that she could stand out and someone would notice. She wanted something that people wouldn't actually notice that she had something done. And you can see the beautiful contours that we were able to achieve on the soft tissue, and how minimal preparation can achieve. You can see that there's no over contour on the labial surface as well, which sometimes can occur. And this was the finished result before and after. You can see that beautiful result that we have there.
Looks very nice. I mean, what sort of opacity do you use for these sorts of...
The good thing about this material, because it's being a little bit more opaque, Bill used an HT material, so just a normal highly translucent material, and we were able to get good opacity. And the real kicker about this material is, if you look at this photo, this is a polarized photo, and you can see that traditionally for a ceramist to get this kind of result of that incisal third, he would normally have to cut back, and then he would layer some translucent ceramics to create that translucent incisal third. In this case, all Bill did was he painted stains on this. He used a material called luster paste from GC. And so the advantage of creating this result with just using a monolithic staining glaze was that we get the full 470 megapascals right throughout the veneer. So there was no weak point in any part of that veneer where it would be more prone to chipping. It was layered ceramics. And we still achieved a great result in this case.
Are we expecting any of that staining glaze to wear away over time, or is it pretty strong?
I think it's glazed over the top, so I don't think that unless you have to brush all that glaze away, which is quite hard for you to do that, I don't foresee that coming off. Yeah. Okay, so that was her finished result. You can see that's her final result and her smile. And I'll get Chris to go through a case of tooth wear.
Okay, so we're going to go on to talk about a case where I've done a tooth wear case. And you can see the patient. She has a very, she was referred for an implant actually. She was referred because she fractured the 1.5. She'd been to see an endodontist and the 1.5 had fractured. But when you look at the patient, you can see that extraorally she has a very brachyfacial facial type. And we know this patient, has quite a lot of parafunction. You can see in the images there, the intraoral images, you'll see, especially on the posterior teeth over here, you'll see in this area here, there is quite a lot of, it's quite short vertical height because there's been quite a lot of erosion as well as attrition. So wear is oftentimes multifactorial, and in this patient, she has both parafunctional wear from bruxing, sleep bruxism, and also she has some acid erosion. You can see on those intraoral images, those occlusal shots, especially on the 6s and 7s, particularly the 7s, there's been significant erosion, and that margin on the buccal of those 7s is pretty much close to that gingival margin. So there's been significant erosion there. She was complaining of sensitivity. She'd seen several people and they tried to carry out restorations, but as you know, there's no room to place those restorations. You know? So in the past, how did we treat these patients?
Yeah, and that's what I wanted to say is it's due to modern dentistry, it's opened up a whole scope of treatment modality with this, because in the past, let's say even 5-10 years ago, we would struggle to restore these without preparation of these teeth. We would be cringing, do we have to crown these teeth? You know, nowadays, Chris, I think it's...
Well, how would you crown this tooth? Because this tooth has no tooth structure. There's no axial height. The tooth, after you prepare it, would probably require endodontic treatment. So you would have to carry a crown lengthening surgery, endodontics, and a crown.
And cut grooves and retention grooves as well.
Yeah. So significant preparation to the tooth. So if you look at the OPG, you'll see that she has a bridge from 1.5 to 1.7, and the 1.7 has an apical area that was noticed on the cone beam CT, while the 1.5 had a fracture. So the 1.5 was extracted, and if you look at the treatment plan, you'll see the steps. First of all, is working out the etiology and taking preventive measures. So we might, in this case, the patient had posterior wear. So when I'm looking at the case like this, the patient has posterior wear. What am I thinking? I'm thinking the patient might have some sort of gastroesophageal reflux disease. So this patient is best off referred to your medical colleague to manage that. The other thing I'm thinking about is obviously she's a bruxer. Maybe she requires a splint. There may be some acidic environment. Maybe some tooth mousse might be a good thing to use as well for this patient. So the patient had the extraction of the 1.5. The endodontist carried out endodontic treatment for 1.7, and implants were placed for 1.5 and 1.6. Now this patient with tooth wear, as you saw, there was no room to place restorations for this patient. So we need to open the vertical for this patient. So we have to open the vertical, and in this patient, this is the perfect indication for no preparation onlays. And I'm very passionate about this because I've seen so much dentistry in the past that's been quite destructive. In this patient, we are able to place onlays on top of those teeth to build up the vertical, cover those exposed areas of dentine, and manage the patient's sensitivity. In the anterior teeth, we carried out some direct resonance, and she also had the bridges replaced on the 2.4 and 2.6. So if you look at the patient, you'll see we took a TRIOS scan, so it's a digital workflow here, and in this patient, it's designed on our CAD software. We're designing these little onlays that fit over the teeth, and you can see the amount of wear that this patient has, significant wear. So you can see these onlays being constructed, and as they're being constructed, basically we have to manage the occlusion. So here you can see these are minimal thickness. We cannot raise the patient's occlusion by too much. And in the anterior teeth, because we are opening the vertical, I've had to also build up the lower anteriors to bring them back into occlusion. So you can still see that there. Yeah.
Chris, do you find that by the time you take out all these old restorations that they may have had in the past or some reverse wear, you actually do achieve that minimum thickness that you require in these restorations. So you don't actually have to open up that much to achieve that minimum thickness.
Yeah.
And what would you say would be the minimum thickness you would be happy with in the posterior segment in terms of your indirect ceramics?
So it really depends. So the minimal thickness from the manufacturer's instructions is always around about 1.5. But if you have good enamel to bond to, I'm much more confident that that's going to have what they call the lamination effect. The lamination effect is when you have porcelain and you bond it to enamel, it takes on the strength of the substrate that you're bonding to. So if you have good enamel to bond to, then I would be probably happier with 1 millimeter. But in this patient, because she has dentine exposed, I want to have a minimum thickness of at least 1.5.
And I think what you highlight is very important because the substrate that we're working with is really going to determine really what our design of our restoration, because if it was completely dentine, you would definitely design this restoration completely different versus what you have now where you have majority enamel and some dentine in there as well.
So if you look at the stone model, you can sort of see the significant erosion there on those models. And you can see those onlays. Those onlays are finished. They really have an infinite edge on the buccal and lingual. So they're sort of wrapping around the enamel a little bit as well, just to give you a little bit better adhesive bonds. And you can see the restoration of the implant restorations. And in the mouth, these are what they look like. I feel very comfortable with this for the patient because I've done no preparation to these teeth. If a tooth fails, if a restoration fails, it's very easy for me to place another one back on for the patient.
And you would have not have removed any tooth structure.
You know, behind.
Yeah.
And there's the finish. So you can see here in the final images, there's some direct composites in the anterior mandibular mandibular anterior teeth, and on the posterior teeth, these Lissi onlays that have been placed.
Okay, so I think I would like to discuss with you Armando here, who's actually our live patient for this evening, and who's kindly decided to come in and help us and show us what this type of material can achieve. Tonight will be the reveal for his permanent crown, so we'll really have a good chance that how this ceramics is created. And this, again, the ceramic work was done with Bill Moraes in the States. And so I'm also excited to see what the final outcome is going to be like. I will talk a little bit of brief history about Armando. Armando was referred to me by a friend and a colleague who wanted me to place an implant for him. So basically, Armando broke his front tooth, and he's 77 years old. He's retired. He's very relaxed, and he just wanted something simple. He said, "Anthony, I just want to place a tooth back there." So we wanted to. The treatment objective was to be minimally invasive, do something simple, and give him a really good outcome. And he was happy to go through that process. So we know that this tooth, you can see that it was definitely not restorable. The goals for this treatment was simple, to be minimally invasive, to be functional. And again, in our practice, we always try to use a digital workflow these days. So we did this case with no impressions, and basically it was completely digital. So we first scanned him with our Trios scan, and we did a pre-operative scan, and then we basically placed this scan and our cone beam CT scan, and we morphed it together into Implant Studio by 3Shape. And I like this software because it allows me to design my own surgical guide. I want to be able to design my own surgical guide. I want to make sure, I want to plan the case, and I want to be able to use a system where it had good libraries, good digital libraries. So I decided to do an immediate extraction, an immediate placement, because I could see that there was sufficient bone there. And I wanted to provide him with a relatively fast temporary restoration and then move on to a permanent restoration. So from the Implant Studio, you could see that I've positioned that slightly palatally, where I engaged it into the bone. I have plenty of bone to engage into. And then I designed my 3D digital guide and my surgical guide. And basically I printed this guide, and I was able to do this guided surgery. And one of the things with, I guess, Chris, you will know, you'll be the expert in this with implant placement, is that sometimes implants do move during placement. And the advantage of having guided surgery is that, we're able to stabilize that and basically accurately place the implant where we are.
Well, especially in immediate placement, because you're normally trying to engage the palatal wall, and your burr often drifts forward, labially, because it always goes to the path of least resistance. So it's very easy in a case like this to let your implant drift too far labially.
Exactly. And you'll see in the next picture where obviously this is our surgical 3D printed guide. We printed it with a simple 3D printer, and this was for a BioHorizons implant. And you can see on the left, that's the guide from the surface and from underneath the fitting surface. And this is the case where we atraumatically removed the tooth using some peritomes, simple atraumatic extraction, and using the guided spoon technique, we were able to place this implant. And you can see that we didn't get any drifting, as what you discussed there. We were able to engage in that palatal bone. We then obviously grafted the jump gap with some artificial bone, and then we were able to then do basically no sutures. And we put in a scan marker at the same time. You can see here, this was on the same day where the implant was placed, was engaged and grafted. And then we were scanned a BioHorizons scan marker. And then we were able then to get Bill to make me a immediate temporary crown that was delivered to me. And this was
a nice temporary crown.
It's beautiful.
And that was with a hybrid material with a CeraSmart milled, because it was done digitally. We didn't want to use any wax. And then I fitted that and I allowed that to integrate now. And this is the final crown here. And I'm gonna go down and see Armando and see what this is gonna look like while you guys go through some other things.
We'll get to some questions while you're getting ready.
Excellent.
So, Chris, going back to the case you presented a moment ago, your onlays, were they ceramic or zirconia?
So they were Lissi press,
They were
so
Lissi,
lithium
so-
disilicate. Yeah.
Excellent. Okay.
Onlays.
And the follow-up
And
question...
the reason why we want to have that is because we're trying to bond to the tooth structure. Zirconia in that situation really wouldn't be able to bond very well because you don't have that retention form in that situation. So this case is specifically indicated for like a lithium disilicate material.
The follow-up question to that is, how much of the OVD did you increase?
OVD increases are done for different reasons. We oftentimes increase OVD for aesthetics, phonetics, those sorts of issues, occlusion, but this was really for restorative convenience. So in this case, we just needed enough space for those restorations. So roughly about 3 to 4 millimeters of OVD increase. And if you look at the studies by Abduo, who's done a very nice review of OVD, He's saying that basically you have up to 5 millimeters. You're safe to increase the OVD. Okay, so this case was about 3.5, 4 millimeters.
And is that measured interincisally or from interocclusally?
Well, it's from any 2 points. So it could be interincisal, it could be from your nose to your chin. Any 2 points. It's just a measurement that we use.
Okay. Another question. Hello, I'm a rural dentist and on occasion do cantilever bridges. Are all ceramic materials of sufficient strength for those situations compared to PFM?
So it all depends. So everything that we do in dentistry is about case selection. So if your patient is not a heavy bruxer, then maybe you are able to use some of these materials. But they also have to be of certain size. So that connector of that cantilever has to be at least, if you're going to use, say, a zirconia restoration, you want to have at least 9 square millimeters of zirconia as a connector size. So I would be happy with like a 1-tooth cantilever on, say, a full arch bridge, say an implant bridge. That would be my sort of, this is a distal cantilever. Mesial cantilever, sort of similar. I'd want to have maybe 1 tooth.
Okay. And the Edelhoff study you mentioned mentions all ceramic crowns as being more conservative than the metal ceramic crown. Does that apply to zirconia that is laminated with lithium disilicate? So
these materials, it does. So with these all ceramic crowns, we are definitely reducing much more. So when you're saying to me, I just want to clarify the question. So you're asking about lithium disilicate pressed onto zirconia, or you're just talking about in general lithium disilicate and zirconia? If you're talking about those materials, you can get them down to 0.3 to 0.6 to 1 millimeter. So the minimum thickness for, say, Lissi would be about 0.3 millimeters. Ideally, we want to try and have, say, 1 millimeter of axial reduction. So in general, to answer your question, that's a lot less than metal ceramics, where we want to have at least 1.2 to 1.5 millimeters of reduction.
Okay. And for a Lissi crown itself, how would it, that is monolithic, how is it actually constructed in the lab?
So basically what happens is there's a few different ways of doing it. Most labs would wax up a tooth. They'd wax up a tooth and then they'd actually invest that wax up, a bit like the lost wax technique with gold. So they'd invest it into an investment, they'd burn out the wax, and basically the Lissi gets heated up and pressed into that investment to form what they call the pressed ceramic. So that's a typical way of doing it. There are other ways of doing lithium disilicates, in that they can do CAD as well, CAD-CAM, and machine pre-crystallized lithium disilicate as well.
Okay. Well, I think our patient demonstration is ready, so let's go round to Dr. Mak.
Hello, can you hear me?
We can.
Excellent. So I've got Armando here. This is his temporary crown, you can see. So we've got the ceramics back. If I can show you, that's his crown, his final crown. So let's take this temporary out. Let's see what this is going to come back. So this case was completely done with photos. We weren't able to send the patient to Portland in America, so we just used a series of normal photos and polarized photos with some shade tabs, and we were able to ask the ceramist Bill to do his magic. So there you go. Temporary is out.
It's very nice gingival architecture there from that provisional crown.
And I think that's the beauty of immediate, Chris. As you would know, it just gives us a great soft tissue result.
And you took a trial scan for this one as well.
That's fully digital, so there's no impressions.
Because in the past we'd be doing like customized impression copings, to actually take an impression of this. But I can see your crown actually matches quite nicely, the gingival
and I think
architecture.
we can achieve this with digital dentistry, Okay, so I think we've got a pretty good, nice result there. You can see the contours of the crown. You can see Bill's mimic the cracks and the lines of his adjacent tooth. And I think he's also tried to copy the cervical areas. So what I'll do is I'll try to take a photo. I think we got it pretty close. I mean, coming from just photos alone, without having to send the patient there. What's your opinion, Chris?
It looks beautiful.
I'd be very happy with that crown in my own mouth.
So we're just going to torque this in now. Excellent. 35 newtons. This is a BioHorizons implant. And so we've got a nice traditional hex connection. And so I'm just going to quickly fill this temporarily, and then I'm going to set the Mondo up, and then we're going to take a photo so we can see if we can bring it up what it looks like in the photo. So maybe you can go to a question, Chris or Peter.
So a question we have here is, do you have any concerns about bonding resin to dentine margins?
So you're talking about direct resin, composite resin?
Well, or using a resin cement onto a margin that is dentine for a Lissy crown, for example, or a Lissy restoration.
So we know that bonding resin to dentine is not as predictable as enamel. Enamel is very successful, very predictable, very long term. We know a lot of studies have come out more recently about dentine bonding deterioration over time with MMPs and those sorts of enzymes that break down that dentine bond. And also a lot of these bonds are very hydrophilic, water-loving, which also hydrolyzes the bond and breaks it down. So when you have a bond to dentine, it might mean that over time you might find some staining around the margin. You might get some micro leakage around the margin. So in cases where you have significant dentine exposure, or say gingival recession, it might be better to change your treatment to another option, like a crown, where you're cementing something in. If you look at Fradiani's studies, he's shown that you have 30% more failure when you have a veneer in dentine margins. So I would always be very careful in those sorts of situations. When you have dentine, that's not as a predictable bond as that to enamel.
Okay. And when you are bonding or using a resin cement on a dentine and enamel prep, how do you go about preparing the surface of the tooth?
When I carry out any type of adhesive dentistry, I like to use air abrasion. And I blast that at 40 psi, so it's not cutting of tooth, it's cleaning the surface. So I have a very, very clean surface to bond to. And then I'll carry out my normal bonding procedures. So if you're going to use a self-etch bond, then I would use my primer adhesive combined, and I would follow the manufacturer's instructions. Very, 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 very important that you read the instructions and follow that exactly.
Okay. Well, I think Dr. Mak is ready for us again, so we'll switch back.
Basically, you can see Armando here. That's his finished crown. We'll get it pretty clear here. Just move it across to the middle. Okay, nice shape, excellent contours. I'm going to take a photo of this now, and maybe we can see how it's going to look, okay? Yep. Okay, great. All right, just smile for me. Yep. Close a little bit, pop your chin down for me. Chin down, that's it, good. Okay, great. That's a pretty decent result, I think. Excellent. So I'll come back up now.
Chris, you mentioned air abrasion. Do you then go for a selective etch technique?
Yeah, so I like the selective etch technique, and this bond by GC, the Premier bond, you can actually use selective etch, you can do a total etch, or you can do a completely self-etch. So selective etch is what I like to do, and that means that I will etch the enamel first, and then followed by my primer and adhesive.
Okay, and the selective etch, is that essentially to avoid MMP activation in dentine, or?
Yeah, so we want to minimise the acid on dentine, because we know that acid activates those MMPs. So if we can minimise that, then that's the best scenario.
So I find often that when I'm trying to selective etch, realistically, some etch will get onto dentine. Yeah. What should I favour? Etching the enamel well and accepting that some dentine will be involved, or the other extreme? I think
that's why these manufacturers have designed these adhesives in that way, in that they can actually do total etch, they can do selective etch, or they can do self-etch. So it actually doesn't really matter if you do get some on dentine. They've done it on purpose that way, because we know that it's very hard to control that etch just on that enamel. We know that we get a bit on the dentine. So no one's that good.
I'm greatly relieved because I was feeling inadequate. So what's the next case, guys?
Okay, let's move on. So I wanted to share with you another way we can use veneers or minimal preparation. And this is quite a tough case, and it was a good case to share with everyone. And this is what we got, unilateral veneers. Now, I think, Chris, Peter, you all know how difficult single tooth veneers
I'm sweating a bit.
can be. Can you imagine how unilateral veneers, matching symmetry, matching the colors perfectly, how difficult it can be? And I think we got a very good result with this case. And in this case, I worked with a Japanese ceramist, and this was from Miyoshi-san. And we basically, again, did it with photos only, and we got it first go, and we got an excellent result. There was a time that we probably didn't think we would get the actual lab work in time because he was going on to his holiday. But he managed to get this case for me, and it turned out to be an excellent result. So this young lady is Antonia. She again gave me consent to use these photos. She actually looks after my son in childcare. That's how I met her. And she's getting married. And she presented, and she wasn't happy with some of these old composites that she had. And you can see here the old composite veneers she had, the 1.1 and 1.2 were deteriorating. They had chipped in the past. And hence, and you can see there was patched up before already. So she was a little bit hesitant to consider using composite again. So she was asking, what can I use and still get a great result? And look, I think composite was definitely an option here. But because of the previous history of chipping, we wanted something a little bit more stronger. We were hoping that we still had some very good enamel down there, so we were able to get a nice, beautiful result with ceramics, and that was obviously an option that she wanted, and I thought we could get probably a better result. So we took some preoperative polarized shots, and you can see the level of detail that we had to mimic. We had to mimic some intensives, we call these white spots that are on her teeth. You can see the old composite being naturally translucent, and you can see that's where you get that graying effect. It's just the nature of the material, and you can see how it's deteriorating around the cervical area. So I sent this as a traditional approach. I took an impression and I sent this to Miyoshi, and he basically did a mock-up. I asked him, can you copy the 1.1 and 1.2 exactly to the T? And I said texture was really important to me, because I think when you can add the texture dimension to ceramics, and Chris, I'm not sure if you agree with me, you really take that aesthetic level from good to excellent, because no teeth are ever flat. You know, I've never seen a natural tooth that's ever flat at all. So this is the wax up that we got back from Daisuke. And I decided we were going to remove the composite during the prep appointment. And you can see here, we were chipping away at the old composite, and I did this under a microscope where we were able to remove all the old composite first. Then we would do a mock-up. So just to check that we were happy with the contours, because at this point, if there was changes to be made, this is the point that we would communicate with our technician, especially him not being able to be here, and especially for me not being able to send the patient to him. The mock-up is really, really important. And at this point in time, we would just try and we'd take photos to make sure that we're happy with the length of the teeth, the shape, the contours, and everything. And we were very happy with this. So then I did minimal preparation for this for these veneers. You can see that I just kept them all on the facial surface, and it was still fully within enamel. I used some retraction cord to retract, but you can see my preparations were still on enamel in the cervical areas, which is what we always try to achieve where possible.
Are you worried about the appearance of those margins after cementing?
No, I think because these are retracted with retraction cord, once the retraction cord has come out and the veneers are bonded, you'll find that they're probably equigingival. And I'm very comfortable with equigingival if we're bonding to enamel, because I know we can get a harmonious approach with the new all ceramic materials. This is one of the advantages of all ceramics versus if we went with a metal ceramic crown, where we would have to hide the shadowing or the darkness from the metal, or if we had gold margins, because we want to be conservative, we would have to hide that subgingivally, which in most times sometimes can cause some gingival irritation. I think the best prosthodontists out there are able to do that without it, but sometimes it's difficult to achieve for everyday dentistry. So the advantage of all ceramics gives us that ability to be able to finish these margins slightly above gingiva equigingival or slightly subgingival. You know, I'll be more wary if it's very deep subgingival, because then we'll be concerned with the ability to bond. So if I find that I can't get full isolation to bond, then I would really consider my preparation design. I may not use a fully facial veneer. You know.
Yeah, the enamel is very thin at that region. You know, Ferrari's done some studies, and that enamel was around about 0.4, 0.5 millimeters. So if the deeper you go subgingivally, the more you're going to be in dentine. And you'll see it. You know, one of the questions often gets asked is, do you need to hide the margin in these sorts of situations? You don't, because you'll find that these restorations will blend in beautifully. Once you adhesively bond, it has a chameleon effect, or the contact lens effect. It blends in beautifully, and you won't even see the margin.
And I guess going back to what you were talking about earlier, Chris, with caries being the greatest enemy of indirect restorations, the more supergingival, the more cleansable.
Yeah, more cleansable. It's better periodontally. It's easier for you as a dentist, because you can take an impression much easier than trying to do something subgingival. You can finish your margin in a much easier manner as well, and you can actually access your margin, polish it. You can see it. You can see if there's any recurrent caries, any micro leakage.
And I guess, Peter, if you're worried about caries, enamel is the best defense for caries. You know, much better than dentine or root surface. So having finishing it on enamel where you've still got some enamel there, that's your best defense for recurrent caries and leakage, I guess. Yeah. All right, so let's move on. And these were the veneers that were pressed, and you can see that Miyoshi-san had copied these to his wax up and created some beautiful textures for me. And you see how thin that they were. And we fitted these in, and I wanted to highlight, by having just equigingival preparation, you could see during the preparation I retracted the gums, but once the retraction got come out, you can see my preparations were literally equigingival, and you can see the beautiful soft tissue that we were able to achieve on the day of cementation. And I think that we can all agree, if we have inflamed gingiva, bleeding gums, there's no way that that we're going to be able to get a nice bonded restoration in that case. So this was the final result. This was the reveal, and she was really happy with this. You can see how she smiled. I think we achieved the brief for unilateral veneers. I think we copied all the textures, all the intensives, the shape. We got everything pretty spot on, and this was done first go. And that's all to the talented ceramists that we have, you know, around to create veneers, which without having to see the patient, we're able to achieve a beautiful result.
Yeah, it's a tough case too, because I noticed that the 1-1 was slightly discolored too. So I noticed that you were able to block out most of that discoloration with this veneer, and that's not easy to do sometimes. So if you look at that image, you see that there is some discoloration around the cervical. So
and that's the beauty of this material. I think we're able to achieve a really highly aesthetic material that is also got a bit more value and opacity in there. We're able to mask these slightly dark teeth, which traditionally we use a very translucent material. We would have a problem with some graying or some shadowing in around those areas. So I'll show you the polarized image at the end, and I think we got it pretty spot on as well. You can see the details of there. It was a really nice result. You know, my philosophy is that we don't need the tooth to be exactly the same as the other one, because each tooth has its own anatomy. But as long as some of the details are there, we're able to blend in and create a harmonious result. And that's the finish for this case from the amazing ceramists from Japan.
Very happy patient. We have some questions regarding that case, Anthony. So how do you deal with gingival recession if it appears during the cementation appointment? Or possibly between the prep and the cementation appointment?
Yeah, I don't feel that we should get gingival recession if we I think one of the causes of potential recession would be probably overpacking cord during the preparation stage. But if you just go nice and gentle with the cord preparation, you will find that you would get minimal recession. And if you did, you would just have to make sure that you bond that really well. You have the option of re-prepping it if you needed to and then take another impression. But generally, to avoid that will be all down to the planning stage, really, just to be nice and gentle to the tissues, really creating beautiful temporaries, because if you don't have good temporaries, you inflame the gingiva, and when you have gingival inflammation, you will find that that's going to cause some recession there.
So to me, I'm thinking, do I really worry about gingival recession in this situation? Because in this case, it's all ceramic. the tooth color in this case is not bad. So if you get gingival recession, you still have the tooth structure there. It's different if you were making that tooth a lot whiter, then you might be concerned about gingival recession. But the advantages of these materials are that you can have that chameleon-like effect. So even if you get recession, your margin isn't even seen. And that's the beauty about this.
And I think also is that you also have to assess the patient's smile line. You know, if they don't have a very high smile line, if you get a slight gingival recession, is that of a concern? You know, it's always, I mean, it's great for us to think that we want everything to be perfect, but does the patient see it? Does the public, when they smile, do their family and friends see it? You know, and if it's not visible, that 1 millimeter of recession is, if you got, like you said, with all ceramic materials, is not a concern. Yeah.
Next question, Anthony, which material did you use to do the diagnostic mock-up to check the contour and surface texture?
Which material? I used GC Temp Smart. So it's a new temporary material, and I really like it because of its polishability. I use it as a final temporary material as well. And it's a dual cure material. You can light cure it, and basically you can use any form of temporary material if you wanted to. You could use a flowable composite if you needed to as well, and that's it. But you make sure that you probably don't. I wouldn't bond to the tooth. I would use the natural undercuts of the tooth to retain that while I'm cutting back and doing testing the mock-up. But any sort of temporary material or flowable would be a perfect scenario for those.
Your temporary was very nice though, that you used. You've used some OptiGlaze, is that right, to get the stains?
Which one was this? For
this Armando.
You're talking about the.
Well, look, either I think is,
okay.
is
for the veneers, we just used a Temp Smart, and we just basically polished that, you know, with composite polishes, and it finishes up with a very high shine. With Armando there, we used a hybrid material, which is a millable material, because we did that digitally. We wanted something that was millable and simple and mill very nicely, and that's why we use Cerasmart. And I think Bill finished that with some stains, which are called OptiGlaze stains, which is like a resin stains, and that's with the nano properties in there. So yeah.
Okay. And what information and protocols were used to relay the shade to the ceramist if the ceramist is unable to take shades with the patient live?
Look, a good series of photos. You know, I always take as many photos as possible. So you definitely need to take a natural photo with raw flash. I definitely wouldn't use any sort of soft lens or bouncers at the time of shade taking. I would definitely taking it at different angles, from a side view, 45, 45, and a front on. And I'll take it with a shade tab in there, a standard shade that a technician is easily reproducible. Sometimes nowadays with a lot of technicians is that for them to be able to reproduce and take the exact photos, we actually use composite. So if you use a blob of composite that they have access to, and usually of an opaque shade, like a standard AO2 opaque shade, and you blob it, or you use two types of composites, they can actually use the same composite in the laboratory and take the photos, and they can contrast that to their lab before they've finished the job. So using some shade tabs or some composite materials is a very good way. And I always take some natural photos and some polarized photos. And the polarized photos are not used to take the color. Okay, there's a lot of misconception that polarized is used for. We use that to highlight the details of the tooth, the little intensives, the little characterizations that just come up straight in those photos, because there isn't that specular reflection there. And that's really important, because that gives it that nth degree of detail to create a beautiful restoration.
Chris, what's your protocol?
It's pretty much the same. I know that these days there's a lot of that ELAB protocol too, but
yep.
Do you ever use that ELAB protocol?
I've started using that ELAB, but you know, I've never had too much problems with you. I think communication with the technician, and obviously with these aesthetic cases, and I think it's really important to know that you can't expect to just start off with a new technician first time and expect to get that bond. It's like you're dating a girl. You can't expect to get that interaction straight away in your first date. I mean, I know some people do.
That good, Anthony.
Sorry, but obviously, you know, it takes time to build that relationship, to build that love, that you're getting that perfect restoration.
He's really smooth,
so, you know, and I convey, I'm very passionate about my teeth, and that's why I talk about this. But yeah, so please do a few tests, do some posterior teeth first, build that relationship, see what you each other like, because he's going to be very good at some things and he may not be as good as other things. So you need to have that harmony between you two, that you're communicating well, and for you to get these beautiful, predictable results.
And next question before we move on, what do you use for bonding bonding a temporary veneer?
a temporary veneer. In this case, look, I struggle with bonding temporary veneers because most traditional temporary resin cement wouldn't hold a facial veneer, and I'm sure Chris would say we used to. There are techniques like we used to tack cure, basically spot etch a small spot in the area, and we use like a flowable composite. We only bond to that very small area on the surface, and then we'll flick that off. Nowadays, I'm moving to a product which is probably not used much anymore. It's actually one of the first GICs that GCs produce. It's called Fuji One. And basically, it's a GIC resin cement which is white and opaque, which is visible. And I just use that. I find that for my onlays and for my veneers, anything where I need retention, it just gives me just enough so that I can either flick it off or get a little artery faucet for my onlays just to peel it off. And I can see that GIC that doesn't bond to the tooth and it's white, and I just basically ultrasonic that off or micro etch it off. So, you know, and I don't know if there's any equivalent of that. This was the very first GIC that was made. It comes in capsule forms. And I always recommend that through my GC reps. Yeah, and I find that it's worked to a T. Yeah.
Nice. Well, it's a real blast in the past. I've not.
Yeah.
I mean, I've heard of it, but not ever worked with it.
Excellent.
So, Chris.
This is the last case, and it's a case that really transformed the patient. It was a full arch implant rehabilitation for this patient. You can see she's a very young lady, and it's quite heartbreaking to hear sometimes these stories of these patients. And you can see she's really not in a good way with her teeth, pretty much a terminal dentition. You know, we talked about saving some teeth, carrying out orthodontic treatment. You know, it would be a pretty long process to try and correct her smile and improve her self-esteem. So this patient, you can see she has quite a high smile line. She's a gummy smile as well. And you can see the intraoral shots. You know, pretty much all those teeth have catastrophic failure, and they really can't be saved. There were probably several teeth that we could have tried to maintain, but in the end we discussed that, whether we should try and keep teeth and carry the implants on the edentulous spaces or to take out the teeth and place implants. In the end, we carried out implant treatment for the patient, both upper and lower implant rehabilitation. So in the maxilla and the mandible, you'll see in the mandible that there were implants placed, and also in the maxilla with some bone grafting. After 3 to 4 months, in this case I should mention I immediately loaded the implants. They all attained good stability. So that patient walked out with teeth, and immediately she was very happy because she could smile again. After 3 to 4 months, we go through the process of carrying out the impression taking, we carry out verification of the implants, and we do the wax trying. That wax trying, we check the phonetics, we check the occlusion and the aesthetics. You know, the patient's happy with the vertical dimensions. She's happy with how these teeth look at this wax trying stage. This patient wanted the best aesthetics. You can understand, you know, she's been through pretty much years of not smiling and lack of self-esteem. So this case, we carried out a zirconia bridge in the maxilla, and in the mandible, we carried out an acrylic titanium hybrid bridge. So this is the maxillary case, and this is what I've been doing for quite a lot of my full arch cases, whether it's either zirconia or titanium. This case was zirconia, and you can see the crowns. You can see on that image, you'll see these crowns are milled out of wax, and then they were pressed using Lissi. And the beauty about Lissi is the fact that you have much less reaction layer. Reaction layer is that layer of investment that gets stuck to the lithium disilicate.
I've experienced this, Chris, as well, that you get a much better reaction, almost non-existent reaction layer. So you get to keep the details of the tooth, especially on the surface.
So normally you'd have to sandblast it away. So here you're keeping some more detail. And there's the wax up case. You can see that's been pressed. That's what I was telling you, Peter, about the lost wax technique.
Yes.
And they're the crowns that are placed on the zirconia bridge. And the zirconia bridge itself is pink porcelain is wrapped around it for the pink. I have tried many other ways of doing it, composite, acrylic, but I find that pink porcelain is always the best. You know, it's more biocompatible, more inert for the patient, doesn't pick up stains as well. So here, these are the Lissi crowns. You will see these are all bonded onto the zirconia frame. And really, the rationale behind why I'm doing that is the fact that, you know, if one tooth breaks, one crown breaks, you know, the patient bites on a fork, bites on an olive seed, I don't have to replace the whole frame. I just have to replace that one tooth. And the beauty about digital dentistry is I can just get that one crown made very, very easily, very quickly for the patient. There's the framework. You can see on the maxilla, there's a zirconia bridge, and then the mandible is an acrylic titanium hybrid bridge.
So Chris, can you comment, what was the rationale between using a ceramic on the upper and then acrylic on the lower?
So we all know that ceramics are hard and the acrylic's a little bit softer, so it has that impact absorption. So in other words, that has a bit of give. Sometimes people call it the sacrificial arch. It's the arch that gives way first or wears preferentially. So I know in the maxilla, that's the most important area. And teeth won't chip off, whereas acrylic teeth might break. We know that the studies by Papaspiridakos in 2012, these acrylic hybrid bridges, now 30% break in 5 years. By 10 years, 60% of these break. So for me, in the maxilla, I like to have ceramic because I know that's a much stronger material. In the mandible, if they lose a tooth, something breaks, it's not such a big deal for the patient. We can easily get it fixed. But you can see a nice integration of the framework, and we want to make sure that there's sufficient space for cleaning. You know, that's very, very important in these sorts of cases. The patient wanted very white teeth, as you can see, very bright teeth. And you know, in this case with Lissy, it really gives that opacity. I've noticed that sometimes in the past I've had some low value cases. So this patient, you know, you can see the transformation for this patient. You know, it's significant for the patient.
She'll be so happy with that. Yes, you know, yeah. She'll be smiling straight away. It's a beauty of what we do, isn't it?
Yeah. I mean, there's just beautiful restorations. You know, even though these are bright, it's a bright shade, it still has that vitality within it. You know, sometimes when you get really bleached shades, you don't see that sort of vitality of the teeth. So these teeth were actually layered. I don't know if you saw that. The incisal edges were still layered with some feldspathic porcelain to give you that aesthetics. And you talked about surface texture. We try and place that surface texture into that ceramic as well.
We've had a question, Chris, if you'd be able to explain more about the temporization step for that patient.
So for this patient, she basically on the day of surgery, we took an impression and we made acrylic ridges on temporary cylinders. So she walked out on the same day. For my practice, because I have a lab on site, I make the prosthesis on the same day. So normally it's an acrylic bridge. It's reinforced with metal. It's like a braided metal wire that gives it some reinforcement. And the patient's advised to have a soft diet for 6 weeks. The 6 weeks is that time for bone to start to grow onto that implant and start to remodel. And so I tell patients the soft diet, there's pasta, fish, rice, noodles, mincemeat, those sorts of things for that first 6 weeks. After that, then they can start eating slightly harder foods. But I'm still a little bit cautious because we're immediately loading these implants.
Understood. And a question also, how were the Lissy crowns attached to the zirconium framework?
So the Lissy crowns were bonded on with a resin cement. So we can use link force and Premier Bond to bond that Lissy pressed crown onto zirconia, and you'll form a very nice bond that way.
Okay, that's actually a good segue into what we need to talk about. We are almost out of time, but I've been advised that GC is running a promotion at the moment where if you have a Lissy crown constructed by your technician will be able to provide you an authentication sticker for that restoration. If you send proof of having a Lissy crown made, GC will send you a complimentary starter kit of GSEM Link Force. So look into that with your technician and with either Henry Schein or GC. Thanks again, and we'll see you soon on ScheinTV.